start off with, there are 12 vertebrae within the thoracic spine. They occupy the posterior aspect of the thoracic cavity. They are the support of the ribs, the rib cage that goes around the thoracic region. The ribs attach to the vertebrae via costal facets or demifacets or facets. They all are a little bit different in what it means. I'll go over that a little bit. Facets on the transverse process for the articulation of the tubercle of the rib, except for in T11, 12. And remember, 11 and 12 are floating. 1 through 8 are true. Then we have 9 and 10 that are false ribs. Sorry, that's my cat. I guess she wants to learn about ribs today, or vertebrae. Okay, so we talked about the difference in the shape of a cervical vertebrae versus a thoracic versus a lumbar. The notable difference between the thoracic and the cervical and lumbar would be that the cervical has the vertebral foraminas, and that the lumbar spine has a rounded spinous process. What's notable about a thoracic is these facets that the tubercle of the ribs actually attach to. That makes it a little bit different. Also, we talked about the spinous process having a greater degree of angulation inferiorly. We're able to flex forward quite a bit, but if we extend back, those spinous processes lock on top of each other, not allowing us to hyperextend our back going backwards. Okay, but commonalities, once again, a body. Posterior to the body is going to be the pedicle. Posterior to the pedicle, going outward, would be the transverse processes. Also, there is the superior articulating facets. Behind the transverse would be the lamina, and then the spinous process. So all the same words, same things, but where they are located or how they are located vary a bit. So for example, when we talk about the facets, they are different at a different angle than the cervical. Note how if I drew a line through the mid-sagittal and crossed for the coronal plane, cervicals were at 45. These happen to be a little bit more posterior, more towards the coronal plane. So they do look different. And that's a dead giveaway when you evaluate and look at different vertebrae. From a side view, do note the spinous process and the amount of angulation that they have. So like I was saying, the one inferior to it and the one superior to it, lock them together to where you're unable to hyperextend your back backwards. So also, once again, the body and the different attachments of the ribs. We have a facet, superior costal facet, or it could be a demifacet. Demi means two, or a half facet. This is the full one. The facet for the costal tubercle of the rib attaches there. And then here we have a demifacet, a half a facet. So what makes it unique is that only T1, only thoracic vertebrae number 1 has a full facet. C1 and 2 at the inferior and the superior part have demifacets for the second rib. I'll get to that in just a second here. So also note that the higher the C-spine or the higher the thoracic vertebrae that we're looking at, the more the angle of the spinous process. Note how the body is smaller on the upper thoracic versus the lower thoracic vertebrae. Note how large the body is of T10, and also how the spinous process is now starting to round off. That rounding off is a transition into the spinous processes of the lumbar spine that allow you to flex backwards because they're rounded. When we arch our back backwards, our upper spine stays pretty much straight to a degree, unless you're double jointed or a contortionist. The lower lumbar is what's actually flexing back or extending backwards. And with the lumbar, or excuse me, since we're talking about thoracic spine, is the thoracic spine a primary or secondary curve?
Primary.
Primary. And how do you remember that, Mia?
I just read it in Merrill's when I was doing it.
Fair enough. Remember, the easiest way is fetal position. A fetus is usually wrapped up tight forward, knees drawn up, elbows down, so they're rolled over. That's the primary curve, and that would be of the thoracic. Easy way to remember it. So, costal facets and demifacets. Starting off with T1, superior portion of the body has a whole facet. A facet is where the rib, the head of the rib, attaches to. Inferior portion of the body has a demifacet. That demifacet connects up with T2 that has demifacets, both superior and inferior. 2 through 8 all have demifacets, meaning that the ribs attaching to the demifacets are halfway in between the vertebrae above and the vertebrae below. 9 superior demifacet, there is none on the inferior side, and T10 through 12 have a whole facet. So when we look at it, these blue spots, highlighted spots, are the facets, or depending on what vertebrae, it would be a demifacet. Note, we have a whole facet on T1. Also down here for the floating ribs of 11 and 10 or 11 and 12. Yet 2 through 8 have a superior demifacet and an inferior demifacet. It has to have both demifacets for the rib to attach to, a whole facet. Questions? Okay, moving on. When you get a chance, I think this is an important picture, especially when you compare it to the cervical and the lumbar, to really understand and be able to visualize this, because this is how we look at, for the thoracic, the zygoapophyseal joints. Now remember, earlier I asked a question, well, what position on the cervical do we see the zygoapophyseal joints? And Drew answered lateral. We're not looking at the zygoapophyseal joints in an oblique of the cervical. We're looking at the intervertebral foramina, which is an odd one. So, anterior up top by the body, posterior would be the spinous process below. Mid-sagittal plane, horizontal plane, or the coronal plane across from the transverse processes. The superior and inferior articulating facets that make up the zygoapophyseal joint lie at 20 degrees from AP, or 70 degrees from AP if they're lying on their back, meaning you have to rotate that patient up 70 degrees. from an AP, or if the patient is lateral on the coronal plane being perpendicular to, we can go 20 degrees back from lateral or 20 degrees forward from lateral, which would change it from an AP to a PA, oblique. Following? I mean, this is, I see a couple head nodding, which is good because now you're wrapping your mind on the direction of rotation of the body and how it changes. So if I was able to turn this vertebrae on its side, so the body is over here, the spinous process would be over towards the left side of the screen. In a perpendicular, and I rotated the patient forward, now the patient would be in an RAO, correct? Or excuse me, LAO. So the patient is placed in the left lateral. Let's go that direction. So if you want the left lateral to be started over here, I'm fine with the left here, right here. Let me see if I can get my pad working here. Whoops. It's on the wrong screen. Nope, I can't. Darn it. I'll have to fix that. So let's start off patient in a left lateral. Everyone can imagine a left lateral, correct? We can rotate the patient forward 20 degrees, and we would be in an LAO position, correct? From a left lateral, rotating forward, you're going backwards, rotate forward. There you go. That would be an LAO. In an LAO, we are looking at the zygapophyseals that are closest to the IR. If we rotated from a left lateral and rolled the patient back 20 degrees, then the zygapophyseal joint over here would now be perpendicular to the IR. The patient's position would be an LPO. Then we're looking at the side furthest away. Moving on. Starting off, what would this one be up here at the top?
Body,
You got it here.
pedicle,
Pedicle.
Superior articular facet.
Facet, or no, it wouldn't be a facet, it would be a process.
Process.
It's a bony structure. Correct. One down here. Kind of an odd one, a costal facet. Here.
lamina,
You got it. Lamina. This one down at the very back.
spinous process,
You got it.
transverse process.
This whole thing here.
Oh, sorry. Vertebral foramen,
Foramen or canal. Here.
Transverse process.
Transverse.
You got it. You got it both. And the last one.
Supercostal facet.
You got it. You got it. Oh, I guess I had animation here. Didn't even know about it. Okay. So I'll give you the first one, pedicle. What is this?
Superior costal demifacet. No, that might be a full one.
That's a full one.
So just facet.
That's that. Yep, correct. The one below. This would be a demifacet.
Inferior.
Mm-hmm. Inferior. It would be a demifacet. Here, didn't really talk about it.
Costal. No, it's the arch of something.
Yeah.
Vertebral.
Vertebral notch, correct. The vertebral notch would give us the intervertebral foraminus. The one above, the one below. Allows us to see the intervertebral foraminus. What goes through the foraminus?
Nerves.
You got it, nerves. Down below here, you have one on either side.
So Bruce, that
Yes.
inferior vertebral notch there, that's the one that's like angled at 20 degrees, or
That would be this one. This is the facet, or the ZA, excuse me, zygapophyseal joint.
oh, okay.
So this would be the superior articular facet. The intervertebral notch with the one vertebrae above and below, when they come together, they make a circle. And that is seen on a lateral. While on a cervical, it's seen on the oblique.
Okay. All right. That makes sense now. Thank you.
These are the ones below that articulate with the ones above.
Inferior.
There you
And those are
go.
the ones that on the cervical are seen in the lateral. So
Correct.
flipped.
Correct. They're flipped. Correct. And I'm saying that for a reason. Why I'm really trying to pound that part in. Oh yeah. Normally they have a list. What do you see on this view versus this view? And they'll put cervical, thoracic, and lumbar. Knowing when do you see the intervertebral foramina? When do you see the zygapophyseal joints? What degree of rotation do you see the zygos at? Okay, long process at the back. Spinous. Here's our lamina. I think it's a poor view of it because you can't really see it, because it would be between the spinous process and the transverse, which this one would be the transverse. I don't think I like that one that much. How about this site?
Costal facet.
Costal tubercle. Facet for the costal tubercle. So that's where the neck of the rib attaches to. And the last one. This was the inferior articular process. This is the,
Superior.
you got it. You got it. These are the ones we do. Normally, a T-spine routine would include an AP and a lateral. Very rarely, but I'm hearing certain places do the obliques, and every place probably does a scoliosis film for the curvature. But with the AP and lateral, oftentimes they will also require you to do a palo. Do we remember what a palo is?
It looks at the costothoracic.
Costothoracic, true. If the patient was upright, standing up, left side against the board, left arm above their head, right shoulder down, what would that be called?
Swimmers?
Palo.
That'd be a swimmers. Swimmers is a general term we use for whether they're upright or supine. But to be specific, if a patient's lying on their left side, left arm above their head, right shoulder down, and you're centered at C7T1, that is a palo.
So the difference is whether they're erect or supine?
Yeah, but yet we use the term swimmers for all of them. And actually the one upright, there's small variations where it's not only a swimmers, but a twining method. They all come together under the term swimmers. But I want you to know that if the patient's lying down, because I've heard this question coming up, if the patient's lying on the table,
Hello.
it's a palo. You know, it's not as if the ART is trying to trick you. Well, why do you think?
Boot camp module had a good way to remember that, and that if they're lying down, they're going to be using a pillow,
Mhm.
and you remove the pillow and put their arm there. It's a palo.
There you go. There you go. And what I found is that when going through the review on the spine, we tend to assume we know the answer as we're reading the question, and the first thing we think of is the swimmers. You know, that's where you really got to slow down on these questions and read what are they asking. So a lot of the times, if they're unable to see all of the thoracic, and depending on where the patient is actually injured or hurting, they may require a palo. And why I say a palo is because of the fact that most T-spines are done on the table. Why are you better off doing a T-spine on the table than upright?
For motion?
Good job. Motion. And it's motion on the lateral. It's motion because a lateral should be done with a breathing technique. And anything over half a second, you're going to see motion, probably even a quarter second. So to minimize motion, you have them lying on the table. So if they're on the table for the lateral, you're going to do the AP and you're going to do the palo on the table. Just makes it easy. Okay, so for an AP, pretty straightforward. 14 by 17, it's going to be done in a portrait, 40-inch distance. You are going to have your central ray halfway between the jugular notch and the xiphoid process along the mid-sagittal plane. Keep the length from top to bottom, your 17 inches, but collimate in side to side. A T-spine should never look like a chest x-ray. Aren't we centering at the same spot? Basically at the level of T7. Well, T7 on the posterior PA we can find, but how we find it on the anterior is halfway between the jugular notch, which is directly underneath your thyroid or your thyroid cartilage. It's a little notch where the clavicles come down into the manubrium of the sternum. And then we know where the xiphoid is and just estimate where halfway is. That is what you need to know for Merrill's. Now, normally what occurs is that when imaging at the central ray, we tend to get L1, L2, and sometimes L3. And note how this is T1. You can see the first rib coming off. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12. There's a floating rib. So we tend to actually have a little bit more lumbar than we have of the upper cervical, and we're cutting it fairly close. Well, you know, there's arguments that you want to center at T7 because of the fact I'd rather radiate a little bit lower than get the thyroid. Valid. So that's where T7, 3, 4, 5, 6, 7 comes into play. But when you look at this image, is it really centered there? I would say it's centered, well, let's see, probably somewhere here. A little bit lower. If I drew a diagonal from corner to corner, I'm going to be about here. Yeah, T8. I'll be right around 7/8. So they might have centered a little bit low. But do note also, note the collimation side to side. Note how we're not seeing the lateral border of the chest. That is called a chest x-ray. This is a thoracic spine. Note where they put the marker. I personally like to place my marker up top and on the right side. And the way to figure that out, you have a 14 by 17. Divide the vertical, the long axis of the plate in half, and divide that half by half. So now it's a quarter. That's where I place it. I don't mind if I get into the cervical. We have this much room down below. We could center a little higher if we wanted to. Collimation actually could have came in a little bit here too. It's a little wide, in my humble opinion. So, T-spine anatomy, intervertebral foraminas. I'm throwing this back out, yeah. Intervertebral foraminas are demonstrated on the lateral projection. Zygapophyseal joints are shown on the oblique, opposite of the cervical. You guys are going to nail it on this. They're opposites. So, the lateral. This one's done upright. I don't know how they did it, especially when a breathing technique, suspend respiration on your AP. Have them hold their breath. A lot of the times, there are times where you might want to have them take a deeper breath in so the diaphragms drop down a little bit lower. So more of the vertebrae, thoracic vertebrae, are more contrasty. But definitely for the lateral, suspend respiration, 14 by 17 in a portrait. We're going to center once again at the level of T7. And we're going to take it to the posterior half of the coronal plane. So normally we would be centering directly under the axillary portion for a lateral chest, correct? That should be halfway between the front and back, right under the armpit. We'll take the coronal plane and divide that in half. When you position for it, you can literally feel along the mid-sagittal plane the spinous processes of the thoracic vertebrae. It lies posterior. It lies more posterior than you think. The other thing that I think is really important in your positioning is that you make sure that the patient's very erect. Note how this patient does have a slight curvature of the spine. It might be because he's rolling his shoulders forward, but you get an older patient that's really kyphotic, it's difficult because the upper thoracic vertebrae is really going to deviate away from your image. Now, the other thing is about a 15 to 20 or 10 to 15 degrees cephalic angulation. This is more noted on this image. Now, do note I put it in red because I believe on the picture it said 15-20. Yeah, I double checked the book and they changed it between editions. Okay. Now, the reason for the angulation, I would not do an angulation if they're upright, but then again, we probably won't be doing lateral T-spines upright. But when they are supine or laying on the table, when a patient has wide shoulders, narrow hips, the thoracic vertebrae goes down at an angle. Hence why we could do a 10 to 15 degree angulation cephalic to match the angulation of fall from the shoulders to the hips. Following? Now, it doesn't mean that we only do 10 to 15 degree cephalic. In some of the older Merrills, they show where a patient may have wider hips and narrower shoulders to where their vertebrae drops towards their head. Therefore, I would change my angle and do a caudal 10 to 15 to minimize or to get around having to angle, note how this patient has sponges underneath their thoracolumbar region and also in the lower hip region, or above the pelvis, actually. These sponges are there to make it so that the thoracic vertebrae is parallel to the table and perpendicular to the IR, or perpendicular to the CR. This is one way of minimizing it. Placing the sponge underneath to raise up the hips. So now the long axis of the thoracic spine is parallel with the table. Okay. Do note also, what is back here behind the patient?
Lead shield.
It's a lead shield. Why do we put a lead shield?
Reduce
lead-
on the table.
Reduces or absorbs the scatter radiation off of the thoracic spine so that it doesn't expose the image. Yes,
Lead rod.
collimation helps. But then again, this other part will improve the image quality. Yes, there was another question. Okay. So no sponges underneath. They did a 10 to 15 cephalic angulation to match the fall of the thoracic spine. So, decent lateral spine. Do note how sharp the body of the vertebrae are. Do note how sharp they are. Note how the ribs look blurry. That's a dead giveaway to a breathing technique. Dead giveaway. Note how the posterior ribs are superimposed, meaning that in the position for the lateral, they made sure that the patient's shoulders are perpendicular to the IR, that there's no rotation in their hip or shoulder, and making sure that they're perpendicular. Remember back when trying to get a chest comp on a lateral, how difficult it is to get that patient rolled perpendicular? Yeah. So same thing here. Note how there's very little tissue between T7 or let's say 6 through 9 on the posterior side, which should tell you that the thoracic spine really lies in the posterior quarter of the body. Note the foraminas are open. You can see the circle. There's a vertebral notch. The notch itself, when combined with the vertebrae above and below, create the intervertebral foramina. Note how you can see it down 10 and 11 combined intervertebral foramina, 11 and 12, 12 and 1, intervertebral foramina. Even the 1 and 2, you can see an intervertebral foramina. So that should give you a clue on what view we see the intervertebral foramina on a lateral, for a lateral or for a lumbar, which is a lateral, which means the zygopophyseal joints are seen on the oblique, opposite of the cervical. Okay. Personally, this is just my personal opinion. This patient could have been centered a little more posteriorly, meaning that it would have been more over the body. If I drew a diagonal, once again, I think they are a little posterior to the spine. And this is where positioning so matters when you're utilizing an AEC. If you're not centered, if your cell is not centered over the vertebrae, you're going to have an underexposed image. I made the comment last year that those that live by a phototimer die by a phototimer, because if their positioning is not exact, they're going to do repeats. So this is where we start really thinking and developing our critical thinking of techniques. It's beginning. It started during your first semester. And then, because it is a breathing technique, we got to think about what we've learned about breathing techniques. 2-second exposure, and then what happens to our MA? What about our KV? Yep, MA goes down. KV should be, on film, we used to go down to 50 kVp. But on average for DR, CR, you can stay at 70. You really can. But definitely very good. Also note, remember how the vertebrae of the lower thoracic vertebrae were more, the spinous processes were more horizontal? And when we get down to L1, notice how round they are, how much space there is in between. But as we go higher between, let's say 8 and 9, note we see the spinous coming down on 8 and 9, there's little space. It doesn't allow you to extend backwards. Okay, so between the two, which one do you like, left or right?
Left.
Left.
Couple lefts, I agree. Notice how the vertebrae are sharper, the bodies, more contrasty, the ribs are blurred out. We're looking at the thoracic spine.
It almost looks like on the right one that he's like rotated in, like his shoulder was, you know what I mean? Like he's off
Well,
or
here,
out. Maybe he's out more.
yeah, here is the humerus coming up. Here's the humeral head. This is part of the scapula. Oh, there's the scapula right there, this line. Note how we know this is not a breathing technique also because you see one hemidiaphragm. Which hemidiaphragm's higher?
The right?
The right side's higher on the liver than the left. We see both of them. Look at the one on the left. Because of the movement, you don't see it. And you thought we only take images. There's so much there. So much interesting things that you can view on a radiograph. Okay, moving on. Oblique. AP or PA? Doesn't matter to me. I think it's actually easier doing it in a AP, especially because of the patients on the table as they are. It's easier to rotate them posterior for, in this situation, the position of the patients in the, RPO. So we talked about it just a little bit earlier that if I rotate the patient posteriorly, and now the patient's in the RPO, what zygos am I looking at? The left or right?
Left.
Correct. If I rotated the patient forward, now the patient would be in an RAO, correct? Which ZAs am I looking at?
Right.
Correct. So why not just do them in the lateral position, roll them forward and backwards? Then you got the left and right ZAs. Makes sense. So once again, 14 by 17, 40-inch SID, 40 to 48 actually, but 40-inch SID. Once again, the centering is exactly the same at T7. There is no difference. Position the patient by rotating the anterior or posterior 20 degrees so that the coronal plane is at a 70 degree to the IR. What they're saying here is that there is a 70 degree angulation by rotating the patient posteriorly 20 degrees. Or if I rotate him anteriorly, flipping the triangle around, it would be once again 70 degrees. So in this image, the position would be RPO, correct? What ZAs are we looking at?
Left.
Left. That is correct. That is correct. So, you can do them upright. You can place them in a lateral, and I don't know why they're actually doing a right lap. I know, I just find it easier keeping it all left because we have to do a left lateral. And you can rotate the patient forward and backwards, and note how the one furthest shoulder furthest away is going forward and rotated away from the spine. And the arm closest to is posterior to it. Now you may find it's easier doing an RAO or an LAO, just for the mere fact that now you're centered a little more posterior on the patient. Imagining the spine and where it lies within the width of the body. When they are in a PO position, you have to triangulate to figure out where the spine lies. Meaning that there might be times where you may be reaching around the patient to figure out where the spine is and then figuring the width of it and how do I go posterior to find out where it's at. May make it a little more difficult. But once again, it is more posterior. And then you take in consideration the OID of the spine. How much of the rotation causes it to move over? We're talking three-dimensionally here. They're a great challenge. They're a great challenge. They're not done that often, I will say that. But a good challenge to start really thinking about all the variables, all these fun variables we get to play with. Okay, moving forward. So, once again, AP projection, the ZA joint furthest away from the IR. PA would be the closest to. What we're looking at is right there. You can see that line going down through. There's a inferior and superior articulating processes, and there is the joint. Here is a joint. Here is another joint. As you move upward, you start losing it. Oh, there's one right there. They're hard to see. They're very hard to see on the upper. The lowers tend to be a little bit easier. But it's a matter of making sure that the shoulders and hips are at the same level of rotation. You rotate the hips more than the shoulders, you're not going to see the lowers. Now, I'm sure it's true with the Scotty dogs that you guys have shot for the lumbar. Like, what happened to my Scotty dog? Well, the hip down here and the shoulders were in a line at the same angle. Check it. Literally place your hands on top of the shoulder and hip. Are they at the same level? Is one forward? Is one backwards? Align them so that they're the same. Okay, moving on. Scoliosis. National question. All scoliosis series should be performed PA. Should be performed PA. Those of you that have shot a Scoli series, have you shot a PA or AP?
AP.
AP.
Mm-hmm.
We've done AP as well.
Yep. Why is that? Well, one of the arguments is, well, less OID on the spine. True. That is very true. And if I'm shielding the lower gonads from the primary beam, I'm good. But it should be done PA. Less dose to the spine, less dose to the breast tissues. Should be done PA. That's a national board question. But I understand what we do in the clinical. So for a Scully series, they're always done upright. You want the feet together or in a position where it's very, not similar, but neutral, I should say. You would center the patient on the 12 by 36 or 14 by 36, I should say, IR plate. And in the old days, this is an old film screen cassette that we used to use. It was literally 36 inches long. And it would have film in it that were threefold. Something different than what we use today. Upright, CR centered to the IR to include the entire spine, base of the skull. A lot of the times it's still necessary. And I think it depends on the clinical site and also where the curvature is actually occurring from. And they also like nowadays to be able to see the hips. I believe Merrill's needs to be updated a little bit on that part. So here is a Scully film. Remember I talked about before for bone length measurement last semester about a particular ruler that is usually in centimeters that has lead numbers in it so that they can measure. Nowadays they do a scanogram on the CT, but the problem with a Scully done on a CT is there is not the weight-bearing process of gravity causing the curvature to be seen when a patient is lying on a table. Everyone should know that when we wake up in the morning, we're about a ½ inch taller. I'm happy about that. I'm really happy about that. Then the older you get, you lose height due to gravity, due to bone demineralization, osteoporosis. Okay, moving on. Note how I put a lead apron in front at that level. That's where it should be. They also perform a lateral. And note how they actually hang a lead apron. Nowadays, I mean, this is old school. You know, this is the first Razor scooter. Doesn't it look like it? It kind of does.
Yeah, like the chopper vibe though, you know?
Yeah, the ape hangers. So true lateral, and they utilize a board to make sure that the body was perfectly in a lateral position. But that doesn't always happen because scoliosis is the lateral curvature of the spine, but there can also be a torsion or a twisting of it, which would mean that one shoulder, one hip might be anterior or posterior to the other in a lateral. Very difficult. So as I was saying a little bit earlier, the film that we used to use was literally 3 14 by 17s, and they were perforated and folded. Nowadays, we do not see this line anymore. What is it called today? What application post-processing do we do? Or does the computer do?
Stitching.
You got it, stitching. Stitching comes from this portion of stitching the images together. Now, with Scully images you're taking today on the new automated ones, it's a 14 by 17 DR plate that moves from the upper to the mid to the lower. And then post-processing stitches it all together. That all comes from the old days where the film was trifold and we would see these lines and they tried to get rid of them with the new technology. Stitching. Do note, lateral cervical You can see the zygoapophyseal joints. When you get into the thoracic, the foraminals. Notice down in the lumbar, intervertebral foraminals once again. But because this patient has scoliosis, note how the ribs are offset. Even though that the upper shoulders are totally parallel or superimposed, there is a curvature in the spine causing the ribs to be off, a rotation. Now, it may not be as, well, it could be this patient actually right here. This is not too exaggerated in the scoliosis, but we can see that there are some very severe cases that are out there. Not only is there the lateral curvature, in this situation, I believe there's a twisting of the vertebrae also. Once again, the complication from scoliosis is that it doesn't get any better as you age. And because of that, it progresses to a point where the curvature becomes so extreme that it impedes the patient's ability to breathe. Has anyone taken a picture of a patient who has scoliosis and metal bars going down through their spine? Those are Harrington rods. They're fusing all the bones together so that it doesn't allow for that movement anymore. So yes, yeah, Mia. Oh, I thought you were going to say something. Okay, almost done here. So the thoracolumbar region, also known as the Fergus method, is specifically to look at the thoracolumbar region. They not only do it for the thoracolumbar region, but they'll also utilize it for scoliosis because of the curvature being in the thoracolumbar region. So 14 by 17, 40-inch SID. Do note how the patient is PA. Upright and centered to the IR to include the thoracic spine to 1 inch inferior to the iliac crest. Second image with lower extremity raised of convex side. So they're just raising the arms away from the body to allow you to see that region so that the elbows aren't in the same area. Any idea what these two things are on the collimator?
Filters?
Not filters.
Not filters.
Are they shields?
They are shields, Joseph. You are correct. What type of shields?
Well, I looked further into the slides, and they're for the breast.
Fair. Thank you for your honesty. They are breast shields. You can see where the shield was placed on the collimator to shield the breast tissue, which is very sensitive, especially because most scoliosis patients are female and they're usually going through puberty. So there's a rapid development of the cells, and now you're radiating them. And do note down here, notice the Mickey Mouse look? That's a shadow shield also. Now, both of them are considered shields. They're both considered shadow shields because of the fact that they project a shadow onto the patient. There is another type of shielding. Nope, I don't see it here. I thought I had a picture, which literally would be two shields tied by a string or a tether that would be placed over the front of the breast, hanging around the neck, kind of like croquis or your sunglasses, how you hang them. So it'd be a contact shield because it is in direct contact with the breast. That way you can shoot at AP and protect from the primary beam. Moving on, MRI. And that is severe lateral movement of the spine, thoracic spine. I believe that this curvature is not necessarily scoliosis, but there was one PowerPoint in the cervical that I did not record on fractures. Hope you guys took a look at those. Note the body of the vertebrae here. Body is rectangular or square, but as you go up, look at this one. Compression. The anterior body of this vertebrae, set 1, 2, 2, 3, 4, 5, 6, 7, T1, T2, T3, T4. The anterior body of T4 is totally crushed, compressed. Whether it's due to an accident, I don't know, but you can see how bad it is. Now also, same patient, here's I said T4. Note this darker gray line coming all the way down. The white is more fluid, cerebral spinal fluid around the nerves. Notice the bulge disc. Notice how it's impinging upon. Ouch. God knows what type of ailment he or she may be having. No idea. I'm not a doctor. I don't get paid the big bucks to make a diagnosis. So when you look at your images, there's so much more information. Keep your eyes open. Keep them open. Here's my last slide. Isn't that the truth?